Thank you all for joining us. On behalf of the American Heart Association and our Quality, Outcomes Research and Analytics team, welcome to today's webinar, Quality Improvement and Health Equity, Using Data to Inspire Equitable Care. My name is Natalie Navarre, and I'm a Quality Improvement Manager specializing in our Get With the Guidelines resuscitation module. Before we begin, I'd like to quickly review how to use the webinar platform for today's event. If you'd like a copy of today's presentation, you can download a PDF in the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that doesn't work, please contact the GoToWebinar customer service team found in your confirmation and reminder email. After today's presentation, you'll receive a link to access today's recording and an invitation to complete our feedback survey. Feel free to submit questions to today's presenters in the questions section. You can type them in anytime and we'll review during our Q&A at the end of the presentation as time permits. It's my pleasure to now introduce our speakers for today. Dr. Shyam Prabhakaran is an internationally recognized leader in vascular neurology and stroke research and treatment. He has been instrumental in reorganizing ambulance transports for stroke patients in Chicago. As a renowned leader in neuroscience research, Dr. Prabhakaran has led projects focusing on uncovering the underlying causes of recurrent strokes, improving stroke care, and optimizing patient outcomes and recovery. His research explores intersections between clinical stroke, neuroimaging, and community health. Welcome, Dr. Prabhakaran. Next, thank you. Next, I'd like to introduce Dr. Fatima Rodriguez. Dr. Rodriguez is an assistant professor in cardiovascular medicine and, by courtesy, the Stanford Prevention Research Center. She received her MD and MPH from Harvard and completed her cardiovascular fellowship at Stanford. She has expertise in cardiovascular prevention and promoting health equity in cardiovascular care and research. She specializes in common cardiac conditions such as coronary artery disease, valvular heart disease, lipid disorders, and cardiovascular risk assessment in high-risk populations. Dr. Rodriguez's research includes a range of topics relating to racial, ethnic, and gender disparities in cardiovascular disease prevention and developing novel interventions to address disparities. Welcome, Dr. Rodriguez.
Delighted to be here. Thank you.
At the American Heart Association, we save and improve lives, and everything we do is grounded in our guiding values. How we do our work as a catalyst to maximize health impact is defined in our strategic value proposition. Addressing both medical and non-medical barriers is crucial to achieving health and well-being for everyone, including those who've been disproportionately affected by cardiovascular disease due to structural racism and other social determinants of health. Our 2024 impact goal, which we strategically developed and is evidence-based, states that by being champions for health equity, we will advance cardiovascular health for all by confronting drivers of health disparities. Our official, more detailed statement on health equity is that everyone deserves an optimal and just opportunity to be healthy, giving special attention to the needs of those at greatest risk of poor health. No one should be disadvantaged from achieving their potential because of social position or any other socially defined circumstance. Now we'll take a closer look at where health equity and science come together. It is my pleasure to turn the presentation over to Dr. Rodriguez to review the AHA's call to action on structural racism.
Thank you, Natalie. Hopefully everybody can hear me okay. I was delighted to participate in the writing committee for this American Heart Association Presidential Advisory Statement that for the first time really called out structural racism as the driver of health disparities. The American Heart Association had previously put out separate papers on disparities by specific racial and ethnic groups and social determinants of health, but this was really an important move to, again, just call it out and have it out there. Next slide. We know that we've made significant gains in cardiovascular disease mortality and stroke throughout the years, but these gains have not benefited populations equally. And we can see here in this graph that Black individuals still face significantly higher rates of mortality as compared to other racial and ethnic groups. Next slide. One of the things that we spent quite a bit of time doing when we worked on this statement was considering the historical context to frame our action steps. History was very important to address because it informs the present and informs the future. And again, this is just an example of a causal pathway, how the history led to the structural inequities that then in turn result in increased cardiovascular and stroke risk factors, toxic stress, increased burden of cardiovascular disease and stroke across certain populations. One of the key things that this statement wanted to do is set forth priority areas to try to dismantle structural racism and form allyship. Those areas include advocacy, leadership, operations, and science is something that many of us are very deeply involved with, but also QI programs and get with the guidelines. And I think that's the focus of this seminar, is how do we use registry data to move forward with our goals for health equity for all. And I'll turn it over to Natalie.
Awesome. Thank you, Dr. Rodriguez. We're now going to look, indeed, at how AHA's quality improvement programs, including all of our Get With the Guidelines modules, are using data to inspire equitable care. Fondly known as our peacock, the image to the right shows our impact areas and reiterates that the heart of our mission is equity. The American Heart Association's quality improvement programs work to narrow gaps and disparities by converting guidelines into clinical practice to improve patient outcomes. Get With the Guidelines is a robust, nationally representative data set with over 10 million patient records entered. Our programs promote consistent adherence to the latest evidence-based guidelines for 6 specific disease states: stroke, resuscitation, heart failure, AFib, coronary artery disease, and, new for last year, COVID-19. The reports sites generate from their input data can be examined all the way down to the individual patient level to shine light on care variation and disparities in care. I want to take a minute to thank and congratulate our hospitals on your dedication to Get With the Guidelines data collection and quality improvement. Across our 5 modules that offer compliance recognition, which is all except for COVID-19, over 1,800 hospitals received awards for their 2020 data. This is really impressive. Thank you all. Beyond Get With the Guidelines, our quality improvement efforts include outpatient initiatives that work together to reduce cardiovascular death, heart attacks, and strokes for those living with hypertension, high cholesterol, and/or type 2 diabetes. We're pleased to share the latest recognition numbers for target BP, check change control cholesterol, and target type 2 diabetes. You can learn more about these initiatives by visiting the website linked at the bottom of the slide. In addition to internal quality improvement, Get With the Guidelines data has also powered numerous publications exploring treatment patterns and outcomes by race and ethnicity, highlighting disparities even in guideline-based treatment and outcomes. Right on the slide here, I have 4 examples, but there are also many more. Thank you, Alyssa. Next slide. One such publication utilized data from our heart failure registry. It showed that Black and female patients were significantly less likely to receive an ICD at discharge than white male patients. Seeing this, the AHA created a quality measure for ICD at discharge. In 2012, a follow-up analysis showed a significant increase in ICD uptake for all 4 race and sex groups. The increase in ICD use was greatest overall among Black patients. Additionally, the 2021 stroke prevention guidelines now include recommendations for health equity. The health equity subsection, shown to the right, is a refocus of the 2014 guidelines section guiding management of high-risk populations. Let's see. Alyssa, can you click it again? All right. In line with the science and our guidelines, and as we strive toward inclusivity, understanding, and customized care, all Get With the Guidelines registries have new and revised field names and options. Here at the top, you can see the edits we've made to gender identity and patient-identified sexual orientation, and at the bottom, you can see the changes we've made to race and ethnicity. We also added a section on health-related social needs assessment to all registries. All of these new data elements are also available to run as both reports and filters. Speaking of filtering, we know that your data is only as good as the information you can glean from it. Here's an example of a Get With the Guidelines report filtered by identified areas of unmet social needs. One way to use this If you're consistently seeing high percentages of patients with unmet social needs such as financial strain or housing issues, you can start bringing in caseworkers to take care of your patients pre-discharge and hopefully address some of these needs. Also, looking at these data allows you to ensure that you're providing the correct discharge instructions for patients. For instance, if a patient has issues with financial strain or housing, you want to make sure that the patient can access and afford a $4 generic statin as opposed to a name brand. Here's another example. Taking the heart failure achievement measure of discharge appointment for eligible patients, maybe your hospital is performing overall at the award level of 85%, and that's great. But you want to look deeper at that missing 15% and see if there's an opportunity to tailor care for certain patient populations. So you run this report, looking at your performance of this measure, filtered by gender identity. This may give you a starting point to look further into the underperforming population and implement QI opportunities. It's admittedly difficult to read the small text here, but what this demo data shows is that gender-queer patients are significantly less likely to have a follow-up appointment made than other patients. Keep in mind, this is from a demonstration account. But drilling down to these genderqueer patients can give you insight into why they might not be following up after discharge. Now we'll look at some resources. The AHA is really excited to be consistently developing content addressing these issues and disparity. Our e-learning platform, which is linked in this slide, has a host of courses available. Please note that this is part of a larger initiative to be launched in Q1 of 2022, and our teams are still refining the approach, content, and the site. Last year, we hosted a Target BP webinar. This is available for your viewing, and it's an excellent resource for training your team on how to actually collect these data points. We encourage our sites to utilize your data for research as well as quality improvement. Our policies for using your data can be found at the website linked in this slide or accessed through your QI manager. If that's not me, you can ask me and I can let you know who it is. I'd now like to hand the presentation over to Dr. Prabhakaran to discuss his disparities research in the stroke population.
Thank you, Natalie. So I'm going to spend a little bit of time maybe giving examples of using Get With The Guidelines to uncover issues in your community and then potentially intervene at the community level or the regional level to try to improve or overcome those disparities that you saw. So Natalie gave some really great examples of how at the hospital level you could use it to target your quality improvement, but I'm going to sort of increase the lens a little bit and go out into the community around your hospital. Let's go to the next slide. Yeah, just some of my disclosures. Go to the next one. Thank you. So there has been, a lot of use of the Get With The Guidelines data, and it's actually a real treasure trove because it provides this ability for us to have truly, since in the U.S. we don't really have a national registry per se, this type of multi-hospital, multi-state data set. And so we can use it for many purposes. Obviously, we can look at epidemiology, and that means looking at trends or risk factors, differences between regions of the U.S. In terms of different quality or potentially even some hospital-based outcomes. And we know, for instance, the Get With Guidelines stroke has, over 5 million patient records in it, which is an incredible achievement. You can also use it to link to other available databases in smaller subsets. For example, you can link it to Medicare databases and then look at the admissions and other outcomes from the original hospitalization. So that's a really common use of Get With The Guidelines data, which I think has been quite successful and really allowed us to learn quite a bit about different aspects of the care we're providing in the US. The other opportunity now that we have better data on many of these aspects of our patients that we care for, including gender, race, ethnicity, and now sexual orientation, is to really look at the issues of socioeconomic status and disparities and how that's playing out. Are patients of all different segments of society getting the same level of care? Are they achieving the excellent outcomes that we hope we can meter out? Or are there really big gaps? And if there are, how can we address them? And then lastly, there are opportunities to really use the data to inform and then help design changes to policies that might be relevant to tackle the issues at the community level. If it's a pre-hospital or acute care level, that's something you could talk to your local stakeholders about. Or maybe it is at the hospital level. Maybe there are things that you're going to change at a group of hospitals or at a single hospital. And that can, of course, be studied as a pre and post, or even in cluster randomization if you were to design such a study. Much of this has been done at local and regional levels, but also at national levels. Target Stroke is a great example. I had the privilege of being part of some of those discussions early on, and now we've really gotten to a point of seeing door-to-needle times come down significantly as a result of a national campaign that achieved such amazing results. But you can turn that lens into other problems that you've noticed in the data locally or regionally. Next slide. One of the concepts that I wanted to go over with everyone was the notion of how do you share best practices using what's been coined as a learning collaborative. Just click one more, yep. And learning collaborative is a concept that emerged from the Institute of Healthcare Improvement over a decade ago. And this concept was to bring stakeholders together, trying to get them to center on a topic or a problem. What are you trying to accomplish? And then really try to set as a goal what you're trying to achieve. And then how will you know that you're making improvements on that problem? What sort of metrics or data are you going to need to monitor improvement? And then in a cycle that you're probably very familiar with, which is called the Plan, Do, Study, Act, or PDSA cycle, you then iteratively tackle the problem, bringing the groups together. One more click. To begin to revisit, learn, act again with the Plan, Do, Study cycle, and you can kind of get into this virtuous cycle where you see improvements and lots of practices being shared between different organizations, different types of team members. And this is a cycle and a concept that we've been using here in Chicago for a number of years. We've sort of built it into our regional stroke advisory subcommittee, which is our regional action committee. But that group includes coordinators, doctors, nurses, others who have vested interest in the stroke system of care. And we bring them together and we bring to them problems that we notice. We provide them with data, we provide them with information, as well as information that might come from other regions or other sources, so that they're really prepared to sort of tackle the issue. And then we begin the process of actually trying to do something. And over cycle, we then try to see if we're making a difference. Next to click. So this concept is really appealing because it's really an all teach, all learn type of model where everybody contributes and everybody's really playing a role in the design of an intervention that could improve an outcome of interest. Next slide. So I'm going to give you 3 examples. We have a lot of examples, but I chose these 3. The first one here is how we use Get With The Guidelines to look at a topic that was maybe prior to this really not well described. And that was the issue of consent for stroke thrombolysis. Every medical decision involves some form of informed consent. It doesn't require written informed consent necessarily, but it does require some form of informed consent. We know that thrombolysis for ischemic stroke is given to only a fraction of patients who come in. And even though approximately 80% of the ones that are eligible might receive thrombolysis, we know that about 20% don't for a variety of reasons. We also know that African Americans are less likely to receive thrombolysis than other groups. One of the things that we were interested in was whether or not the informed consent process is one of the reasons for that disparity in African Americans versus other groups, and could it be something that we could then address in the future. So we were lucky that the Get With The Guidelines did have a item on its data CRF for reasons for not giving TPA for stroke, and one of those is patient or family refusal. So what we were looking at is in our region, because we were really interested in trying to tackle this as a possible community intervention, and we wanted to look at Chicago primary stroke centers using the Get With The Guidelines data. One of the advantages that we've had regionally is that we've had near unanimous use of Get With The Guidelines, if not now unanimous use of Get With The Guidelines stroke amongst our primary and comprehensive stroke centers in the Chicago region. So we really get uniform data, and we can aggregate that for this type of purpose. But what we found was that about 7.5% of patients who were otherwise eligible for TPA were declining it. When we looked at the race ethnic groups, African Americans have about 2 times more likely to decline TPA than whites. And we were really perplexed by this. And when you think about it, you could say, well, there might be educational barriers. But as we just heard a few minutes ago, there may be also structural racism that occurs at the physician or provider level. And that led us to currently be developing and beginning to implement a training program of physicians so that we're giving them sort of a culturally tailored intervention to better understand what some of the issues might be that go into the decision of saying yes to TPA or declining TPA. So this is an example of how we were able to shed light on a topic that had previously not been well studied. Next slide. There's a different example, again looking at the lens of community intervention and disparities. Many of you may know, but if you don't, Chicago is a very geographically divided city by race ethnicity. The south side of Chicago tends to be predominantly African American. And so, in fact, many of the challenges around stroke care actually play out geographically because of the strong linkage to race ethnic segregation. So one of the topics we were really interested in was, of course, getting TPA and other evidence-based acute treatments for stroke depend on arrival to the hospital in the early hours after onset. But many of our patients don't use 911 to come into the hospital, and of course sometimes miss treatment opportunities because they come in a delayed fashion. Once again, African Americans are known to have lower utilization of 911 than Caucasians, and there are many reasons for that. Some of it is actually a lack of trust of the system. Some of it is actually a concern about being charged and financially penalized for using 911. So those reasons may underpin why this is happening, but we were really wanted to try to come up with a solution to improve those rates. We knew that prior mass media campaigns hadn't led to sustained improvements in 911 use. And we knew there were certain pockets in our city where we really had very low 911 use, and we wanted to see if we can improve that. And you can see on the picture here that the city of Chicago had these blue zones or gray zones in the south side of the city where 911 use was in a hotspot analysis lower than other regions of the city. So what we did was we partnered with over 80 community organizations to develop a stroke preparedness or stroke education intervention delivered by community members. And we enrolled 250 or so individuals who became our stroke champions, and they delivered messages around 911 use for stroke in the south side of Chicago, targeting specific areas around a couple of hospitals that were really the focus of the intervention, because they saw the majority of stroke patients. And what we found was we could improve 911 use for stroke after our intervention, and you can see the hot spots changed to the areas, especially around the hospital that we really were most penetrating in terms of our community promoters intervention. And that was a really important demonstration for us that if you partner with the community and tackle a problem that is important to the community, you could see an effect on actual behavior, which was not been shown previously, that you could actually change behavior, not just intent. So this was a good use of how the Get With The Guidelines informed the problem, and then of course helped us design an intervention to improve something that's very important in stroke care. Next one. There we go. So the third example is more of a policy change, and how the data could be used to help us develop policy changes. And then of course in our city, that was again tied to disparities in care, because primary stroke centers in the city of Chicago are predominantly in affluent areas, as it might be around the country, as are comprehensive stroke centers. And so if you don't have policies to take patients to the appropriate center, they will often be taken to centers that don't have the expertise to take care of their needs and deliver treatments that could help them have better outcomes. So we know one of those types of treatments is endovascular treatment, which is now very much an known effective treatment for one of the most powerful treatments for acute ischemic stroke, and yet it's given to a very small minority of patients. We were really interested in whether or not regional policies and transport algorithms to take patients with suspected stroke to the nearest comprehensive stroke center would make a difference on treatment rates. And so we worked with our regional stroke advisory subcommittee, our partners in the Chicago Fire Department, our EMS medical directors, to develop a protocol to identify stroke patients who might have a severe stroke or a large vessel occlusion, and were presenting within a 6-hour window. And then we instructed and trained our paramedics to take them to the nearest comprehensive stroke center. And what we found was that we had dramatic increases in endovascular treatment rates, nearly by threefold after the policy was implemented. And this was almost exclusively concentrated in the EMS arriving 6-hour patients, which told us that this was really a direct policy effect. So we were again able to improve the delivery of a proven treatment simply by identifying a problem and then working with our colleagues around the city to implement a policy change. So these are really, I think, just 3 types of examples of how the data from the Get With The Guidelines was then used to inform, then intervene, and then evaluate interventions that hopefully help us reduce disparities in care. I'm going to stop here and give it back to Natalie.
Thank you so much, Dr. Prabhakaran. I think it's fantastic that that you were able to utilize our data and do it in a such an ethnically diverse place as Chicago, where we know that these disparities exist, and we can now show it, using science and data. So thank you. We'll now turn things over to Dr. Rodriguez to discuss the AHA's COVID-19 registry. Go ahead, Dr. Rodriguez.
Thank you so much, Natalie. And I'll tell you that unlike many of the other registries, there is not so much evidence in COVID-19, especially when we started the registry. So I'll use this as an example to really explore new diseases and launch a registry very quickly during a pandemic. Next slide. Are my disclosures. Next slide. Next slide. So by way of background, early in the pandemic, there was a notice from around the world that COVID-19 affected the heart differently than other viral illnesses. And it both potentiated existing heart disease, but also led to severe complications that were being observed, including myocarditis, vascular events, arrhythmias, and thromboembolic complications. So there really was a need to understand if these were anecdotes based on a series of stories, or if there was really something different about COVID-19 and how it affected heart disease. Next slide. This was, again, early in the pandemic, around March, and I was on the inpatient service, and I received a call from Dr. DeLemos inviting me to be part of a volunteering steering committee to create a registry during a pandemic specifically about COVID-19 and its cardiovascular complications, staffed by superb American Heart Association leadership and staff and site investigators. Next slide. And here's just a timeline that we noted when we started this pandemic. You can see that right after the WHO declared the COVID-19 a global pandemic, just a few weeks after, the American Heart Association decided that we needed to build a specific cardiovascular disease quality registry for COVID-19 and got the groups together. And just a few weeks later, we started having sites recruit and enroll participants. Next slide. So what was different about this COVID-19 registry? We certainly leveraged the existing power and resources and hospitals from the Get With the Guidelines, but this was different because of the rapid need to understand how COVID-19 affected cardiovascular disease. And as we just heard from the last presentation, not only inform research, but really understand local quality improvement metrics and really benchmarks. What are we doing? What are best practices? We wanted to collect data that was granular, but still feasible. We understood that sites were overwhelmed and had a lot of other priorities. We noted over 200 unique data elements, including serial laboratory data, demographic data. And a very important part of this registry was to complete case capture to minimize selection bias, because many of the stories that we heard early in the pandemic, including those published in top journals, were really based on anecdotes or small case series, and we needed to understand how COVID-19 affected the heart. Next slide. One of the key things about this registry is that we wanted to disrupt how we do the research process, and with the standard registries, really the key thing was the need for speed and to have as many people involved in it looking at the data as possible. To do this, we leveraged the American Heart Association's existing precision medicine platform, which is a secure, cloud-based environment that allows multiple teams to work together in curated data. Analysts and teams were encouraged to share their code, best practices. And again, really the advantage here is to shorten the amount of time to discovery. And a lot of these studies were early hypothesis generating, and to disseminate the results, not only from a research standpoint, but also, as we saw, from quality dashboards. And in this case, there are no best practice guidelines, but it was, what is one site doing? What kind of outcomes are we getting? And how do these differ geographically across the country as the pandemic really hit different areas? One of the key things of this process was that we wanted to leverage the existing talent and infrastructure of multiple sites across the nation. And again, many of these hospitals were previously involved with the Get With the Guidelines programs. The challenges included the need to maintain rigor, and especially in an area unlike stroke care, unlike heart failure, unlike many of the other registries where we don't know what the best practices are. We really need to make sure that the data collection process was held to a very high standard to avoid us going down the wrong path and generating hypotheses. And of course, we recognized quickly that there was a clinical priorities, the participating sites, which included, of course, patient care, competing registries that needed to be balanced and managed. Next slide. This is a summary of where we are as of last month and supporting a burst science approach where, again, we wanted to quickly enroll hospitals across the country. There's been some geographic differences as we get more hospitals across the country. But really, when we built the registry, a lot of this was for the volunteer team to call people we knew at all the hospitals, and again, stress the importance of starting this registry and starting data collection efforts across the country with a huge focus on getting racial ethnic diversity across hospital sites and also geographic diversity. And this became increasingly important as we moved through different waves in the pandemic that initially was focused on the Northeast and then eventually made its way to other parts of the country. We thought that this registry, the idea wasn't that it would be forever, but almost a few years later, it's still actively happening. 80 research proposals have been received, 11 articles have been published, and there's many still in active analyses, and the patient records continue to grow in addition to the serial lab data. Next slide. So one of the key things I want to emphasize and tell all of you is that this data set and this registry is meant to be used, and we want to democratize the process. We're accepting proposals on a rolling basis, and if anybody has questions they want to answer, please let us know, and we are happy to facilitate that. The proposal is short. We do want it to be hypothesis driven and have clear aims. And importantly, we want our data set to be able to answer those questions, so the data fields should be available in the registry. The steering committee and a publications committee review each of the proposals, and again, are really given priority based on feasibility and merit, and we definitely want this to be used broadly. Each project is paired with a mentor from the Get With the Guidelines committee that's very familiar with the data field process and the data analysis process, as well as the topic area of interest. One of the key aspects of this registry is the decentralized approach to data analysis. Most of the investigators choose to use the precision medicine platform from the American Heart Association, with their own statistical team at their institution or with American Heart Association statistical support. Or for the more complicated analysis, which I'll give you an example of next, we work with the Duke DCRI to combine some of the data, especially when we're linking with census data or other outcomes like Medicare. There's an agreements that are signed, manuscripts that we follow up on, and then of course the peer review process. Next slide. So I wanted to just spend a few minutes discussing an example of one of the key papers that has come out of this registry so far, and I think won't be a surprise to many of you. But really, one of our key goals was to identify racial and ethnic disparities in COVID-19 hospitalizations. As we know, and we discussed earlier in the discussion, there is significant structural factors that have magnified the racial ethnic disparities in the US, and COVID-19 is one of these examples, and there are many others. Studies had shown early in the pandemic that Black and Hispanic patients were more likely to develop COVID-19 and experience severe outcomes once hospitalized. Next. So the goal of this initial study was to characterize racial ethnic differences in how people presented and what happened to them in the hospital, with a focus on cardiovascular events and cardiovascular severity. Next slide. This was emphasized by Natalie. It was very important that we collected adequate and granular data on race ethnicity is shown here. We disaggregated by major subgroups, and additionally some other socioeconomic metrics that were extracted from the electronic health records at each of the sites. Next slide. So what did we find? So this was data from the initial first cut of the pandemic, again, early in the pandemic. And what we see in the red lines are the American Heart Association COVID-19 registry of participants that were hospitalized as compared to data from the local census where each hospital was located. And clearly there's a disparity where we see significant overrepresentation for those hospitalized for being Black or Hispanic, and these were not areas that were highly represented in the hospitals before the pandemic. Next slide. We also found, not surprisingly, that of the deaths that occur early in the pandemic, and the mortality rate was quite high for those hospitalized in this first wave. There was a mortality rate of 20%. That over half of those who died in the hospital were Black or Hispanic. Interestingly, we did not find that race or ethnicity was a predictive factor for poor hospital outcomes, including mortality, once the patients were hospitalized. So what this means is, back to our initial conversation about structural factors, is that really the intervention needs to happen before people are sick enough to be hospitalized and sick enough to have adverse outcomes, really upstream from clinical care into the societal factors that result in this disparity in overrepresentation of these groups in COVID-19 cases. Next slide. I just wanted to acknowledge the immense work of the Registry Steering Committee, Dr. DeLemos and Dr. Dawes from UT Southwestern, who lead the registry, and we're still meeting regularly. This was a strong effort, but an important effort. We met weekly, 2-3 times a week, sometimes, just to try to move the project forward. And again, I want this to serve as a call for research proposals. We want everybody to use the data. And if you have a good question or want to look at trends or changes, because in the area of COVID-19, there isn't necessarily guidelines or data that we're following, but it is interesting to see how things have changed and if there are any areas that still require further analysis. So with that, I'll turn it over to Natalie, and we are delighted to begin a Q&A.
All right, thank you both so much. Dr. Rodriguez and Dr. Prabhakaran, I would like, if you guys are able to have you join back on video for our moderated discussion. So as a reminder to everybody listening, you can still submit questions for our presenters through the questions pane in your control panel, and we'll address them at the end as time permits. Our team here at the AHA came up with a couple of questions that we wanted you all to address, Dr. R and Dr. P. Earlier, we showed the audience health-related unmet social needs data elements that were recently added to Get With The Guidelines. Over the years, we've seen how the conversation around health equity, social determinants of health, et cetera, has evolved. Can you guys speak to the importance of continuing to expand what and how we collect in a healthcare setting?
Absolutely. I think we both probably have significant thoughts on this. And again, when we built the COVID registry, for example, we wanted to make sure it had all the granular data elements that are available in the other registries. There is a trade-off. There's a trade-off for complexity and having complete data. And of course, if you're abstracting the data, it's only going to be as good as the data available in the electronic health record. So it has to start at the health system collecting the data, so then we can abstract that data into our registries. But it's very, very important. You know, our work in other areas has shown the significance of disaggregation of certain racial ethnic groups, as we're showing in the registry, that not all Asian groups are the same, not all Hispanic groups are the same, and of course getting granular information on social determinants.
Yeah, I mean, I think it's also in keeping with, you know, what is the expectation of our patients and our community. I think people don't want to be lumped into categories that don't fit them. And it's actually insulting, right, when you put them into categories and force that. I think having more granularity is really what we have to do. And then I think, because there are differences within subgroups, it's better to know that than have conflated a bunch of things and then missed an opportunity to identify a problem when one exists.
Absolutely, that's a really good point, and it's something that we come across as we include more data elements in the registries, right? Like how many blanks are we going to give for this, and how many options? And I think the importance of an other box is always going to be there. So thank you. And my second question is both a question and a call to action for our listeners. What would you say to those on the call who are wondering what they can do to encourage adoption of this work?
Yeah, I mean, I think actually most of the time, the people who are frontline and seeing the patients and interacting with patients or their communities actually have the most insights. And their voices need to be heard because they often can really help. Perhaps the researchers are further removed even from that and actually need to hear of the voices who are seeing the problems. And so actually I'm a big fan of encouraging those who are maybe not the ones who want to do the research, but have identified the problem to really participate in that process of generating the data to then enacting potentially a solution to a problem that they identified. So they're really critical because if you don't champion and voice the concerns around equity, others might not see it.
I couldn't agree more, and COVID is obviously a great example of that. The lessons learned were from people on the ground, and we had a presentation at our university from a community doctor who was doing all this himself. He was keeping tabs of who was coming in the hospital and what were their demographics and what were their comorbidities. And this is where a platform like our registries could be very, very helpful for local efforts, again, to try to understand the problem, but also see what resources the hospital needs. And in hospitals, healthcare systems need to provide the resources to allow for this abstraction. And it really is in their best interest to understand their local community and how that differs across the country.
Yeah, I think being champions for the work is so important, and you both have demonstrated how you do that, both as researchers and as direct care providers. So as kind of a segue into some audience questions, I was thinking about how interesting it is that we mostly speak of Get With the Guidelines data as being used for in-hospital quality improvement. However, Dr. Prabhakaran, a lot of your work was on ambulance transfers. And one of our audience members asked, can you give any detail on how the EMS providers were encouraged to select endovascular bowl sites?
Yes, so we obviously as a region have identified those sites by virtue of their certification through external bodies. So they are then endorsed by our region. So a site can't self-designate, but if they've gone through the certification process, they're then designated as a endovascular capable, a thrombectomy capable site or comprehensive stroke center site in our region. And then that list of sites is made public, and the paramedics and the City of Chicago's fire department are aware of that. And if there are changes or updates, those are all done in real time. And they are then able to look at the transport times and traffic and all that kind of stuff and determine the nearest comprehensive stroke center for those types of patients who are eligible for that. So that's really the way I think regions have done it. They have a list of sites and their certifications and their designations, and the paramedics have trained on that.
As a follow-up, can you speak at all to 911/EMS transport costs? What those are like in your region, what goes on nationally? Is that as common a barrier there as it is here in Texas, for instance?
It is. It's actually, probably something that is under thought of and discussed and acted on. In fact, if we wanted to focus on a particular, sort of disparity or health equity issue, it's actually cost of care and EMS care in particular, because it sometimes falls out of the typical insurance coverage that people have. And of course, if you don't have insurance, those costs can be pretty high. It's usually in the order of a couple of $1,000s to do an ambulance, to take an ambulance for emergency care. Sometimes it'll be covered if it's deemed appropriate care. So what if you call 911 and it turned out that you had chest pain from heartburn or a migraine instead of a stroke, and you were then discharged from the emergency room? There is a whole, I would say a series of consequences for that, where patients have told me that they then will get charged for that use, and it will discourage them from ever using it again. They might have financial consequences because they can't afford to pay for that, and then they will tell their friends not to call 911 as well. So there's a lot of implications of what you just said. And, we've talked about it here locally and brought it up nationally at different advocacy forums of how this issue is a real potent problem in this country. And, we need to address it.
Yeah, I don't want to totally take you out of that conversation, Dr. Rodriguez. If you wanted to add anything, you're more than welcome to.
No, I'll just say that my family's from Florida and very similar issues around ambulance care. And my mom was having stroke symptoms, and she's like, no, but the ambulance will take me to this place. And I'm like, and where it designates, you're right, not all the places can do the same thing, and who knows that. So I think it's critically important. It's something that we don't think about necessarily once we're at the hospital, but thinking about how do people even get to the right site that's going to deliver the right care, especially for something like stroke, is critical in reducing gaps.
Yeah. Was there anything that surprised either of you or took your work in a different direction when you were researching?
I mean, I think for me with the COVID-19, everything was a surprise. When we started the registry, we thought hydroxychloroquine was a great idea, and we had just, I think it surprised us how quickly we had to iterate on the versions of the registry, again, because of such an evidence-free zone. And what we thought was a great idea 18 months ago is no longer a great idea, and how things have shifted so much geographically. And again, reminds us of the importance of collecting data across diverse hospitals and diverse patients.
I'll just say one, sort of comment as a sort of a comment on just how things work in science, but also in making change happen. You saw an example of burst science, but I think there's some merit and value to patience as well. And the point there is sometimes change in issues like what we're talking about today really take a lot of persistence. And so our examples here in the city, it's years and even decades in the making of trying to push and get people to gather together and really, as one voice, make a protocol or a change happen. So I think patience is really important if you're in this space, because you're not going to see immediate results often.
Yeah. And then I think just one more. This caller says, thank you so much for speaking to us. This information is so great. For hospitals that are smaller, have fewer resources, where staff are already stretched thin, thinking about health equity is often not at the forefront, especially in times of emergency. Oftentimes we see under-resourced communities or more rural sites that are also those that are disproportionately at risk as well. So is there a way you can think of to tackle this issue when bringing it up for some of these providers?
This was a big issue when we were telling hospitals that were already stretched thin, right, to start building a new registry and start abstracting data. There were small grants and financial incentives that we were working with our partners to try to give these special needs hospitals, because again, it was important to have those sites represented. But we recognize the issues. I think that it has to be a priority of the leadership of the hospital and the resources that you have. And the important thing is to see this registry and see this participation as a tool that benefits the hospital and informs the needs and informs the resources that need to be allocated. But that is often something that needs to come from leadership.
Yeah, we've had similar challenges in Get With the Guidelines stroke. Some of the lesser resource hospitals struggle to keep up, and of course they don't have as many staff who participate or assist in the data collection. So it's really a challenge. We've tried to use somewhat of the bully pulpit of the region to try to then write letters and support to those organizations and those coordinators often to then take to their local leaders, to their hospital leaders, to say, hey, this is an external requirement that's coming to us. It's not just poor little me saying we need to collect this data. It's actually necessary for a larger purpose for our, our region, our state, etc. So I think sometimes asking for help from your colleagues around the region or the state could be a good way to get the attention of your hospital leaders.
Okay, I know I said last question, but we did have one more that I wanted to look at, especially because it really draws that in. So people are wondering what AHA is doing to encourage facilities to capture the valuable information such as sexual orientation, gender identity. A lot of institutions now are not collecting that, and what can we do maybe on a local level to positively affect change? And I think you spoke to that as far as, it's going to be a little bit more macro than just the hospital itself. It's going to need to come from organizations that are trusted and have evidence-based guidelines, such as the American Heart Association, such as, maybe input from a doctor from UChicago or a doctor from Stanford. So I think you spoke to that some, but do you agree that a lot of times it's going to have some external help and or pressure?
I do. I think oftentimes the in the day-to-day of a C-suite of a hospital, they may not see this as valuable until somebody brings it to them and or raises some of the implications of not doing it to them. And then I think that gets their attention. They still need to then, pony up the resources, and that's always a hospital level decision. But I think oftentimes there are resources, they're just being diverted to something else.
I couldn't agree more. And I've seen this at our institution, that there is pressure to meet certain metrics. I think having the brand name of the American Heart Association and saying this is a guideline, and there are consequences for not adhering to these guidelines, and again, in comparison to your peer institutions and nationally, that gets people moving. Hospitals and health systems are competitive, and it also helps having designations like an AHA Gold Star, and especially in comparison to their peers. So that's helpful. But I think knowing that this is one of the highest bodies of evidence for what we do in stroke and heart disease is a huge motivator.
Wonderful. Well, Alyssa, last slide. It's just a quote for you to read. You certainly don't have to. I won't read it out loud to you all, but I would like to thank our presenters and our participants for your engagement in today's event. Reminder, after the webinar, you'll receive a follow-up email with a survey on the presentation. It'll also have a link to the recording, and you can download the slides in the handout section. If you can't get to them, let us know, and we can email them over to you. On behalf of the American Heart Association, our presenters, and Equitable Care, thank you so much for joining us, and have a lovely day.
Thanks, everybody. Thanks, Natalie.
Thank you, Natalie.
Bye-bye.